Good afternoon, everyone. Thanks for tuning in on this session regarding breast cancer. Firstly, I'd like to wish everyone good health and remind all to follow the SOPs and stay safe. I encourage everyone to stay strong and get through this extremely challenging time with the enormous strain that has been laid upon us all, physically, mentally, as well as economically. So now let's get on to the topic in discussion today, breast cancer, which despite being a very well-known entity, it is unfortunately often misunderstood. Today, I hope to provide you with some useful information about this very common disease and hopefully help someone alter their course of illnesses from a hopeless and deadly condition to a potentially curable one. Now, how do we achieve that? The answer is simple: early detection and early treatment. So let's get to the slides. All right. Okay, let's start with the anatomy of the breast. As you can see here, the breast is on top, lying on top of the chest wall, and this is the chest wall muscle. This is the breast, and the breast consists of fat, fat tissue, which is yellow here, breast tissue or lobules, and then the ducts. There are tunnels that channel the milk from the lobules to the nipple. Most cancers of the breast arise from the cells that is lining these ducts or tunnels or the production units of milk. Breast cancer is the most common cancer in women and the leading cause of death for those at the age of 35 to 54, and as high as 1 in 11 will develop breast cancer in a lifetime. The incidence of breast cancer peaks from the age of 50 to 60, as shown here. The risk factors for breast cancer, number one would be family history. The more family members that one has, especially the first degree relatives with breast cancer, the higher your risk becomes. Age is another risk factor. With increasing age, the risk will increase. Body weight or body mass index will, the higher the body mass index, the higher the risk. Now, the exposure to normal menstrual cycle, the duration of which is also a risk factor. So if one starts to have the menses early in age and late menopause, they are exposed to this menstrual cycle for a longer period, their risk will be increased. Alcohol and smoking will also increase the risk of breast cancer. Giving birth to children actually reduces the risk of breast cancer. So, and also the age of the first live birth as well. The earlier it is, the better, the lower the risk. Certain conditions of the breast will also increase the risk of breast cancer. One being a patient with a previous breast cancer, they are 4 times more likely to develop another breast cancer in another part of the breast. Conditions such as lobular carcinoma in situ, LCIS, which I will discuss a little bit further, atypical hyperplasia, patients who had received thoracic or chest wall radiotherapy below the age of 30, and those who had done mammogram and showed increased breast density on mammogram will be at increased risk of breast cancer. Now, this is a very important slide, sign of breast cancer. The most important sign would be a lump in the breast. And most of these lumps are painless. Most breast cancers are painless. Okay, so other signs include nipple discharge, nipple rash, dimpling or swelling or uneven breast surface, a recent onset of a retraction of nipple, and lastly pain. About only 10% of breast cancers are painful. Just a note about nipple rash, since this is quite a common condition. Anyone with nipple rash that is persistent and which continues to erode away the nipple is suspicious of breast cancer, and this should be biopsy to confirm the diagnosis. This is what we call Paget's disease. Pain, as I said, is a very common symptom to breast, and fortunately, it is not a sign of breast cancer. Cyclical pain, which comes and goes according to the menstrual cycle, is very common, and it is not suspicious. Non-cyclical pain tend to be a little bit suspicious, and we usually like to investigate a bit further with mammogram or ultrasound. Now, certain risk factors can be modified, and certain risk factors cannot. Uh, Things like alcohol consumption, if you reduce it, it can actually help to reduce your risk. Exercise, diet and weight control, and of course, breastfeeding. Now, as I said earlier, the important part is to detect breast cancer early. And how do we do that? Firstly, by public education, like what we're doing now. So it teaches everyone to look out for breast cancer, signs of breast cancer, and present themselves early to the doctor. Regular self-examination is very important and should be practiced by every woman above the age of 20, and this should be done every month. The best time to do self-examination would be on the 10th day from the first day of menses. That is when the breast tissue is less swollen and it's easier to detect any lumps that may exist in the breast. From the age of 40 onwards, screening mammography should be done yearly, as we can pick up cancers before they can be felt with the fingers, and this should be coupled with regular examination by the health professional, be it a doctor or a trained nurse. Screening mammogram, as I said, is done yearly for those above 40, and the benefits are: one, we can detect cancers very early. Sometimes we can detect certain conditions that is pre-cancerous, meaning that they are not exactly cancer, but they will become cancer eventually. And by detecting early, you increase the chance of cure, and you also increase the chance of breast conservation. Breast conservation means that we leave the breast intact uh, and not remove the entire breast with surgery. Okay, in Island Hospital, we have the relatively new machine, what we call the 3D uh, mammogram. With this machine, we get a very clear 3D picture of the breast, and it is also more accurate and less painful at the same time. The radiation exposure is lower as well, so that's the benefit of this new machine. And just to illustrate, as you can see in this mammogram, there is a cancer that is illustrated here with the black arrow over here. So the screening guidelines uh, encourage self-examination from the age of 20. Uh, some may choose to have an examination by a health professional every 3 yearly, up to the age of 40, where yearly examination and mammogram is encouraged. Diagnosis of breast cancer rests on history, physical examination, and more importantly, imaging as well, like a mammogram, ultrasound, and sometimes MRI is used. If a patient has a nipple discharge, some of this fluid can be examined to look for cells and determine whether they are cancerous cells. However, these are not as accurate as a biopsy. There are many forms of biopsy. The first one is a fine needle aspiration cytology, FNAC, where a small needle is inserted into the tumor and aspiration done. Cells are then analyzed to see if they they are categorized into either benign, borderline, or cancerous. So this is one of the method. But a more accurate method would be a core needle biopsy, where a larger needle is used under local anesthetic to remove a small piece of tumor from the tissue, from the tumor tissue, and that can be sent to the lab for analysis. Yeah. And of course, the most accurate would be a surgical biopsy where the lump is completely removed and carefully analyzed. The modalities for treatment of breast cancer consist of many, surgery being the most common, and usually we start with surgery if the condition is operable. As I said earlier about breast conserving surgery, we leave the breast intact. We will only remove the tumor in the breast. Whereas for mastectomy, the entire breast is removed. Following which, the choice of chemotherapy, radiotherapy, and endocrine targeted therapy, the choice of which will be made by the oncologist, who will look at all the reports that's ready at the time and decide what would be the best course of action. A word about mastectomy. If a tumor is very large, or there are multiple tumors in different parts of the breast, then the breast has to be removed totally. And that's what we call mastectomy. In patients where radiation is not possible, for example, in a pregnant lady, or in patients where they have sensitive skin to radiotherapy, uh, we cannot offer breast conservation surgery, because if we do not remove the entire breast, they must receive radiotherapy. So that is one of the conditions for breast conservation surgery. Another condition where we suspect there may be multiple areas of ductal carcinomas in situ within the breast, as shown with microcalcifications, or if there is a tissue margin after initial wide excision, which shows that it is still not clear of cancer, then we will have to remove the entire breast. This is a diagram showing what is removed in mastectomy. As you can see here, this is the cancer. We remove the entire breast tissue, which typically lies from the second to the sixth rib, together with the lymph nodes in the armpit. You can see here, this is the cancer, and you have these lymphatic ducts, which may carry cancer cells, and they get trapped in the lymph nodes. It's like a filter. They filter the cancer cells. Yeah? So we will have to remove the lymph nodes to stage the disease. And this is the site. If you have multiple cancers within a small area in the same quadrant, they are still open to breast conservation surgery. But however, if there are multiple tumors in different parts of the breast, then a mastectomy will be required. This is a diagram of breast conserving surgery where the tumor is removed with a clear margin, and the clear margin must be proven on examination in the lab. Yeah? And the lymph nodes are removed as well. Removal of lymph nodes in the armpit is what we call axillary clearance. That's to stage the disease and to control the disease in the armpit. Yeah? Um, Staging of disease means how far has the cancer moved to. Yeah? So I will tell you a bit about stages later. Chemotherapy is a medication that is given to kill cancer cells. It's usually injected into the bloodstream, and it travels around the whole body, hoping to kill any cancer cells that is present at that time. Yeah? It can be given before or after surgery. In patients where the cancer is too big to be removed, we will give chemotherapy to shrink the cancer so that they can be removed uh, at the time when it is smaller. Sometimes we shrink a cancer to allow us to try to do breast conservation surgery, but it is not always possible. And more commonly is given after surgery as an adjuvant role. Adjuvant role means that we are giving it to hopefully kill off whatever cancer cells that's present that may not be detected at the time of surgery with the current means of imaging and so forth. Yeah? Some patients where the cancer is incurable, it can be given as a palliative treatment to give more time to the patient and more comfort. Yeah. Okay, radiotherapy uses radiation to treat cancer. It is absolutely necessary if the breast is preserved. Sometimes it's given to control large inoperable cancer. And also it's also used in treatment of bone pain due to cancer spread to the bone. Endocrine therapy is where we give certain medications like tamoxifen to reduce the hormones in the body, the female hormones in the body, and we only give it to patients with cancer that has receptors for these hormones on the cancer cells. Okay, these are the breast cancer stages. Okay, stage 1 is when the cancer is still small, less than 2 centimeters, and is confined within the breast. Stage 2 is when the cancer is a little bit bigger, more than 2 centimeters, and there may be a few small spread to the lymph nodes. Stage 3 is when there are multiple nodes in the axilla or the armpit that is involved. And stage 4 is where the cancer has spread beyond the breast to another organ, for example, the lung, the liver, the bone, and so forth. Now, this is a write-up about 3 years ago about a journal that was published in the New England Journal of Medicine. It shows that breast cancer can return after 15 years of treatment. Apparently, it can stay dormant for a long time, and some even up to 20 years after diagnosis. So what are the signs to show that the cancer is more curable than the others? Firstly, the size of the cancer. If the size is larger, it is more difficult to cure. If the stage is more advanced, it is more difficult to cure. Now, grade of cancer it often causes a lot of confusion. Grade is not the same as stage of cancer. Grade is the measurement of how fast cancer cells divide. Yeah, so it indicates the aggressiveness of the cancer. Yeah? So the higher grade cancers have lower prognosis. Yeah, and certain characteristics of the breast cancer, like the estrogen and progesterone receptors and HER2 status, do indicate the prognosis as well. Now, breast cancer we can divide into non-invasive breast cancer and invasive. Strictly speaking, non-invasive is not really a cancer yet because it hasn't invaded the space to allow it to spread. Yeah. So there are two types of non-invasive breast cancer: ductal carcinoma in situ and lobular carcinoma in situ. Now, the goals of treatment for carcinoma in situ is to prevent occurrence of cancer, and if we cannot prevent it, we hope to pick it up when it's still very early and localized to the breast. So firstly, about ductal carcinoma in situ. We're seeing more of this condition ever since screening mammography was instituted, and about 20% of ductal carcinoma in situ occurs in different parts of the breast. Yeah. With this condition, there is about 30 to 50% chance of cancer over the next 10 years. It is a true precursor of invasive cancer, and the risk of transformation into cancer is proportional to the grade. The higher the grade, the more likely it is to transform into cancer. So the treatment of DCIS does depend on the condition that we discover the patient at. So it's either removal of the entire breast or just removal of the lump itself, plus and minus radiation. Radiotherapy is shown to reduce recurrences of cancer by 50% in ductal carcinoma in situ. So mastectomy, or the removal of the entire breast, should be offered to those with multiple and multi-centric DCIS or large DCIS or high grade DCIS. Yeah. For those smaller or lower grade ductal carcinoma in situ, the breast may be preserved as long as the margin is clear, and radiotherapy should be considered to further reduce the risk of recurrence. Now the second one is the LCIS, the lobular carcinoma in situ. With this condition, there's about 10 to 20% risk of breast cancer over 15 years. And interestingly, the breast cancer can occur in either breast, not necessarily the side of the breast with the LCIS, and it may be ductal or lobular. Therefore, it is not actually a precursor of cancer. It is purely a marker for increased risk of invasive breast cancer in either breast. So how do we manage this? Basically, there is a choice between watch policy and removal of both breasts to reduce risk. A more rational approach would be to have a lifelong follow-up, close follow-up, every 6 to 12 monthly to look for any early signs of breast cancer. For this condition, there is no role of breast conservation surgery because it is a marker of increased risk. Now about invasive breast cancer. Invasive means that the cancer cells has invaded the membrane to allow it to spread to other parts of the body. The two main types is also ductal and lobular. And something about Paget's disease. Paget's disease is a relatively uncommon cancer of the breast where the cancer cells lie in the nipple areola complex area on the skin, and about 80 to 90% of this condition will be associated with DCIS or invasive cancer somewhere in the breast. Treatment would be the removal of the whole breast, and if there is invasive cancer involved, the lymph nodes in the armpit has to be removed at the same time. Phylloides tumor is another tumor that is a little bit uncommon. It starts off as a benign tumor and it can slowly grow to become malignant over time. The appearance of this tumor on mammogram and ultrasound appear like something harmless, like a fibroadenoma, which is a benign, harmless tumor of the breast. So it tends to grow a bit faster, and that biopsy will be required to differentiate between the two. Yeah. Another special instance is when breast cancer is diagnosed in pregnancy. Yeah. Unfortunately, diagnosis is often delayed in pregnancy because of the accompanying changes in the breast during pregnancy, and a biopsy with a core needle will be preferred at this time, as we try to avoid general anesthesia for pregnant ladies. Yeah. Breast conservation surgery is possible provided the radiation treatment can be delayed until after the childbirth. Yeah. Chemotherapy can still be given in the second trimester to about 35 weeks to avoid hematological complication during delivery. So what is the nature of this disease? It is a deadly disease if it detected late and treated late. So early treatment with an early detection significantly improves the chance of cure for breast cancer. And on top of that, breast may most of the time be preserved if we detect it early. So remember, the best protection is early detection. So we screen it and we fight it. Yeah. So that has come to the end of my talk. So if there's any questions, okay, there's some questions that come up. Okay, there's a question from Lim Tan Chin. The question is, what is the age for late menopause? There is no definition what is late and what is early. Menopause uh, is from anywhere between late 40s, mid 40s to about late 50s. So it is the amount of time that one spends having regular menstrual cycle that matters. Yeah. Another question from CB: breast cancer is statistically more common in the left breast. Is there any known reason why is that so? Well, as far as I know, it is not more common in the left breast. It is equally common in right or left. Okay, as far as I can see, there are no other live questions, and there are some questions that have been posted before the session. Let me see. Okay, there's a question about the link between oral contraceptives and breast cancer, whether it increases the risk of breast cancer. Well, up to now, the studies have not been very conclusive, and in addition to that, the latest form of contraception involves a much lower dose than previously. So, if there is any increase in risk of breast cancer, it will be very minimal. Yeah. Okay, this question: will my breast cancer affect my ability to have a baby? Well, breast cancer doesn't affect fertility, but the treatment of breast cancer may, in particular, chemotherapy. Chemotherapy may damage the ovaries. However, there are still many patients who become pregnant after full treatment of breast cancer. So there is always hope. Huh? There are some patients with hormone receptor positive cancers who will receive anti-hormone drugs from 5 to 10 years. Uh, with these drugs on board, they are unlikely to get pregnant. Uh, Therefore, to be pregnant after treatment, these drugs have to be stopped. So it is a decision made between the oncologist and the patient to weigh the pros and cons of each. And generally, at least 2 years should be given before we decide to stop the medication to try for pregnancy. Does menstrual and reproductive history affect breast cancer risk? I've talked about the menstrual history. The length of menstrual history does affect. Reproductive history, yes. If somebody has the earlier the age of the first live birth, then the lower the risk. How does breastfeeding reduce the risk of breast cancer? Well, we know this fact more statistically from the statistics point of view, but there are some theories that try to explain why is that so. One is that during breastfeeding, a lot of mothers do not have their menstruation, so it reduces the period of exposure to normal menstrual cycle, and therefore risk is reduced. Another theory is that during breastfeeding, a lot of cells from the breast tissue is shedded off, and some of these cells may have been there for some time and may carry some DNA damage. So when there's a continuous shedding of cells and renewal of cells, then the risk of breast cancer will be reduced. But these are theories. How often should I go to my doctor for a checkup? Well, we generally recommend after 40 years old, once a year, but from 20 to 40, for those with higher risk, they should get a checkup every 1 to 3 years. Yeah. If no one in my family has had breast cancer, can I still get it? Well, reduction in risk, okay, doesn't mean there's no risk. If you have an average risk of breast cancer, doesn't mean there's no risk. So yes, you can still get it. So that doesn't mean that if there's no family member with breast cancer, you can't get it. Yeah. If I have a history of non-cancerous breast lump, does it increase my risk of developing breast cancer? Most non-cancerous breast lumps do not increase the risk of breast cancer, except for a condition called atypical hyperplasia. Yeah. So it depends. Yeah. So it is very important to get the histology report after a breast lump is removed, and the doctor will advise the patient appropriately. Are there any foods that increase or decrease the risk of breast cancer? Well, there are no food that will decrease the risk. Certain food will increase the risk, such as sugar, red meat, uh, processed food will generally increase the risk of breast cancer. Okay, what is the difference between a benign breast condition and breast cancer? Okay, a benign breast condition or benign tumor will have cells that will divide uh, in a uncontrolled manner. But the difference between that and cancer is that cancer cells can break out and spread to other parts of the body through different routes, such as the lymphatic system or the blood vessels. Yeah. So benign conditions do not spread; they remain within the breast and they stay there. Can men get breast cancer? Yes. Although our risk of getting breast cancer is about 100 times less than a woman, but yes, men can get breast cancer. And if men feel that there is a lump in the breast, they should get treatment and consultation. So there's no more questions. So that'll be the end of this session. So keep the lumps out of your cups.